Bismillah ar-Rahman ar-Rahim. Inshallah, now we'll start our second session about inborn errors of metabolism in the 21st centuries, current to future. Actually, it's a great pleasure to start by Professor Jerry Buckley. Professor Jerry Buckley is a professor of pediatrics and human genetics at the Department of Medical Genetics of Pittsburgh, USA. He's a chief director of genetics and genomic medicine, Cleveland Family Onward Chair in pediatric research, director of the Center for Rare Disease Therapy. Professor Buckley is going to give a very nice presentation about newborn screening for a new century. Actually, he did a great effort, Professor Buckley, in giving a recorded presentation, but actually he will be with us live and for any Q&A during his presentation and finally in the Q&A time. Thank you.
Hello, and thanks for the opportunity to present to you at your conference virtually. I hope that someday soon I'll be able to do that in person. My topic for this talk is screening for inborn errors of metabolism, approaches for a new century. These are my disclosures, nothing related to this talk. And I'd like to start discussing this topic by asking a very basic question. Why study rare diseases? Why do we care about inborn errors of metabolism and other genetic disorders? Well, although each of them is individually rare, together they're actually quite common. 3% of infants worldwide are born with a genetic problem that requires some attention from the medical system. 0.5% of babies have an inborn error of metabolism. And in the United States, somewhere close to 40% of infant and childhood mortality are related to genetic disorders, as at 50% of childhood hospital admissions. Depending on how you count them, 25% of adult hospital admissions are for disorders that have some genetic component. So it's a much bigger problem than is apparent just by the incidence of any individual disorder. If you look at the childhood, the infant mortality rate as compiled by the Center for Disease Control in the United States over the last, 55 years, 60 years, it's obvious that there's a very large drop over the course of the first 40 years or so of keeping these statistics. And while a lot of this is due directly to neonatal care, maternal care, at least some of it is due to the introduction of newborn screening in the United States. And in particular, the area here in pink is a time when expanded newborn screening was introduced in the United States. This identifies disorders through tandem mass spectrometry, and many of these disorders prior to institution of newborn screening were identified by sudden infant death. Typically a child that got acutely ill in the first few days of life and died before a diagnosis and treatment could be instituted. Sorry, let me back up for a second. As we look at the subsequent years, starting with the new century, the year 2000, this drop in infant mortality has actually been very minimal. It's been quite flat, and in part, I think that's because we've not had a way of expanding the newborn screening as we did during the subsequent 20 years, in a way that's had such a large impact on the infant mortality. And so, if we are to have that kind of impact going forward for the last 3/4 of this century, we're going to need some new paradigms to take effect to help out with identifying and allowing therapy for those disorders. What will that look like? Well, let's start by looking at the diseases that we're talking about. They're rare, and so we don't often know a lot about the variability of the diseases and their natural history. If we don't know what the natural history is, it's very difficult to know whether our therapies are having any effect. It is also difficult to know if we're having an effect if we can have variable presentations. Many of the inborn errors that we know about and already screened for can present with acute life-threatening illness, chronic problems, or intermittent problems that are only present when a child is otherwise has a mild intercurrent illness. There are disorders that look alike, share a common phenotype, but have different genetic causes. And so all of those are not likely to be treated by the same therapy. It becomes necessary to know the exact diagnosis from a genetic standpoint to be able to come up with an appropriate screening tool and therapy. Excuse me. And then finally, we need to take into account normal variation. The history of newborn screening is filled with conditions that were identified by screening sick populations, populations where there was some disease, identifying an abnormality, assuming that the abnormality caused the disease, and then move forward with trying to treat that disease. And in fact, it turns out that some of those are just biochemical phenotypes. You can look at, for example, short-chain acyl-CoA dehydrogenase deficiency, which turns out to be extremely common in the general population, and therefore has been associated in the literature with almost everything. In reality, once it was added to the newborn screen, there appeared to be no consistent phenotype with it. And now most of the states in the United States have moved away from reporting it as an abnormality. Looking at newborn screening criteria that were developed in the last century, the World Health Organization criteria, often called Wilson and Younger, you can see that there were some very general criteria that may or may not be relevant in 2024. Of course, you would like it to be treatable. Of course, you need to detect it in the newborn period. Pre-symptomatic initiation of treatment should be beneficial. Available resources for diagnosis, treatment, and follow-up. A simple method for sample collection, evidence of public benefit and acceptance, a suitable and simple test method, and acceptable costs. So some of these are medical issues, and some of them are societal issues, and may or may not drive the screening for the newborn screening for inborn errors and metabolism in countries where resources just aren't available. As tandem mass spectrometry began to be implemented in newborn screening in the United States, the American College of Medical Genetics put together a new series of criteria that were broader and allowed for some variation from the original criteria from 1968. Instead of saying it had to be treatable and identifiable, it simply said that clinical characteristics had to show a phenotype in the newborn period that were adversely affected if the disease wasn't screened. There was a recognition that the analytical characteristics of the screening test needed to be considered. But the idea of a test being simple, as over here in 1968, was really sort of relevant in the era of tandem mass spectrometry for newborn screening. It's not a simple test, but it turns out it can be implemented in a general way to screen a population. And then consideration of diagnosis, treatment, and management of the condition, both in acute and chronic forms. And here there's some allotment to saying, even if we can't treat it, if we can have some benefit for the child and or the family in terms of reducing the diagnostic odyssey and identifying this sooner rather than later, then it's reasonable to consider it for newborn screening. A quick look at newborn screening paradigms that have been used traditionally. The standard one, looking at phenylalanine for PKU or T4 or TSH for thyroid disease, was one assay, one biomarker for one disease. You either had a positive test or a negative test, which was a low risk or a high risk. Remember, this is not diagnostics; it's risk identification. Or you had something in the middle, and you called that borderline, and that required additional testing. There gradually came to be multiplex testing, where one assay could identify multiple different diseases. And so you can, tandem mass spectrometry is the best example of this. And so you can have any one of a number of markers be low, high, or moderate as above. And it's just that now you're looking at multiple diseases at one time. Well, as we'll talk about in the coming few minutes, the possibility of doing a broad genetic screen, whole genome sequencing, or other technologies, really takes this to a different level, because here you can essentially identify anything you want as long as you know about it. And the question then becomes, is that what we want to do? Do you want to identify something that's going to show up when an individual is 40 when they're newborns? And many of us would argue that that's probably not the right way to go. I'll also offer some thoughts about that in a few minutes. So when we look at what's being done now in the United States, there's an agency called HRSA, Health Resources and Services Administration, that convenes a panel that looks at the relative benefits of adding new diseases to the newborn screening panel in the United States. And they look at the usual criteria, and then provide technical advice back to the Secretary of HRSA. Now, this is a federal program, and it puts out what's called the Recommended Uniform Screening Panel, or the RUSP. But in the United States, there's no mandate to do this at the federal levels. Newborn screening is a state program, and so states are allowed at their discretion to implement recommendations from the committee. In reality, almost every condition that gets added to the RUSP gets added to state screening programs. It just takes a very variable amount of time. So you can see there are now 20 disorders that are considered primary conditions identified by mass spec, some lysosomal storage diseases, a creatine synthesis disorder, and then some non-inborn errors of metabolism, including spinal muscular atrophy, which was added following the development of therapies, and then some other either point of care testing or individual testing that added to the panel. There are secondary targets that are identified by tandem mass spec screening that would not have made the criteria for being added to the RUSP had there been a primary target. But because you can identify them, most of those get added to most screening states. screening panels in most states. So if we now look at what has happened over the past 50 years, pretty much what I just talked to you about, we're left asking the question of what's next. I'm going to take a slight digression and tell you about some efforts to identify serious disease in critically ill newborns by whole genome sequencing. So we were part of a U.S. national collaboration called Gemini to identify genetic disorders in critically ill newborns and up through the age of 1 year. And we actually compared whole genome sequencing with a dedicated neonatal panel to see which one was better. So in that study, 350 babies were enrolled, and I'm not going to go through the algorithm that we use to identify the diseases, but 45% of those babies had a diagnosis that might or might not have been made ultimately if they had not had whole genome sequencing, but certainly would have had it gotten to it later. We did a similar study in our pediatric intensive care unit in babies who otherwise unexplained sepsis with a mild bacterial infection, and here we looked at a number of babies or children, about 1,000 of them. And in fact, we were able to identify disorders of immunodeficiency that explained what was going on in these patients. They may or they may not have come to that diagnosis outside of being in a tertiary care medical center without screening. If you look across the board at infant mortality and look at whole genome sequencing in the context of babies who died of an otherwise unexplained for an unexplained reason, looking, and this is a paper that was published last year now, 112 infant deaths were examined. And the authors found 47 genetic disorders in 46 infants. So not quite half of the babies had a genetic cause for that disorder that would not have been identified otherwise. And in fact, 62% of the death certificates on these 112 infants didn't even mention the possibility of genetic disorder. Noteworthy here is that treatment was available for 30% of the diagnoses that were made up here. So if these babies had been identified early enough, they could have been treated and potentially been otherwise healthy. So does that mean we should be doing whole genome sequencing for newborn screening? Well, the answer is maybe, and maybe for some disorders. Stephen Kingsmore published at the end of 2022 a screening paradigm that looked at 457 childhood genetic diseases that his group deemed to be sufficiently severe to lead to ICU admission. And could be identified by rapid whole genome sequencing. Used a series of reasonable criteria to define those, and then put that panel through a rigorous set of additional evaluations by experts and family groups, and ultimately came up with a panel of 295 disorders that they plan on offering as a rapid turnaround whole genome sequencing newborn screen. they presented some preliminary data from this project at meetings, most recently at the American College of Medical Genetics meeting last month, but it hasn't been published yet, so I can't provide those results to you. But I can tell you that at the very least, there are in fact babies that have been identified, treated, and serious sequelae prevented by using this protocol. So what does this mean for us? It means we really need a new paradigm. That just identifying the things that are easy by today's technology isn't enough, and just screening for things that might be treated in the immediate newborn period probably isn't enough as well, because of the diagnostic odyssey that it sometimes takes to get to the diagnosis of a genetic disease. The problem is that newborn screening using whole genome sequencing does have some downsides. That in particular in the United States, sequencing or newborn screening is variable across states, and of course is variable across country. Parental consent for screening is uneven, and most of us have an opt-out policy for newborn screening, which really probably isn't appropriate when you're talking about doing whole genome screening. Return of results, follow-up are sometimes difficult and are provided by centers that are geographically limited. Even if we identify a disease, treatment in our system is expensive, not always covered by insurance. There's not availability consistently internationally. I mentioned the difficulties in returning results, and there are lots of issues around this. Do we need informed consent rather than opt out? How do we deliver lab reports that are very complicated and can have a lot of genetic information? Who should deliver those results? And of course, you're talking to parents who, even if they give consent, don't ever expect to hear anything about it. And of course, the panic that hits, I would say, not just the parents, but the screening centers when the potential for a critically ill baby is identified. So what's the right way to do this? Well, it really becomes necessary to think about newborn screening as a broad system that requires the ability to collaborate for across screening with regulations that are consistent, engage the population that's going to be screened, and with something as complicated as whole genome sequencing. And it really is going to require a centralization before we're going to be able to scale to do this. There's just no other way to manage it. So now we're left with trying to identify the diseases that should be on that panel, and provide the education that is necessary for our staffs as well as for patients and caregivers around what a disease diagnosis like that means. And enhancing equity across the newborn screening system, or across the jurisdiction for newborn screening, is an enormous problem. Even in a country with well-established newborn screening, universal newborn screening in the United States, you have to be able to democratize across patient populations, and especially if we're going to be trying to implement this not just in the United States but across the world, it's quite an endeavor. It also involves trust of the general population in the field of science, which of course in the era post-COVID has sometimes been difficulty. The bottom line is that if we do whole genome sequencing in the newborn period, what we get is a lifetime of information. Some of that we could deliver back in the newborn period. But why not make those data available across the age spectrum and at 5, 10, 50, unveil the data, look at it and say, okay, you have a particular risk for this condition, and use that to improve the genetic and overall health of our population. Now, the important thing is that this is a very complicated process, and so I highly encourage anyone considering to do it to really work with a consensus group and try to apply this in as broad a way as possible, rather than one-offs being driven by family organizations or particularly influential individuals in the field. So with that, I'll stop. Thank you for your time, and I think there'll be time for questions and answers in the live portion of this session. Thanks for your attention.
Thank you, Dr. Voegtli, for a very nice and scientific presentation. Do we open the floor for questions? Is there any question for Professor Voegtli? No? Okay. It's my pleasure and honor to introduce Professor Ola Khalifa, Professor and Consultant of Clinical Genetics, Department of Medical Genetics, Ain Shams University, Director of the Genetic Unit, Department of Pediatrics, Faculty of Medicine, Ain Shams University. She joined the Genetics Department at King Faisal Specialist Hospital and Research Center in Riyadh for 10 years. She has a lot of scientific publications in peer-reviewed international journals. Her research interest is in genetics and metabolic disorders, as well as skeletal dysplasia. She is the co-author of 2 atlas of genetic disorders. Professor Ola will share with us a nice and updated talk about the classical homocystinuria, current and novel therapeutic approaches. We are all ears, Dr. Ola. Thank you.
Thank you, Professor Yasmin, for this great introduction. Actually, I'll start today a presentation on classical homocystinuria and current and novel therapeutic intervention. My presentation flow chart will be an introduction to homocystinuria. Then I'll pass by the homocysteine metabolism. Then I'll focus on the classical homocystinuria, then the current and the novel therapies for classical homocystinuria, and finally the conclusion. Okay, I will stop for a while. Professor Jerry is on live with us. Professor Omnia, if you kindly want to ask him a question, you can go, please.
Thank you so much, Dr. Jerry, for the very beneficial presentation. I want to ask about cases of SMA. When you start your newborn screening in about SMA, and what are the therapies you are using in USA, and you have how many patients till now on different types of therapy? Thank you.
Well, I'm not sure I have the exact numbers in front of me, and sorry for the confusion on the timing. I was on earlier, and I guess we were running a little bit late. Anyway, SMA's been screening now in Pennsylvania for probably 3 or 4 years. We are using both the nusinersen and the Spinraza. and we have done about probably about 7 or 8 gene therapies now, with good results. So it really is the only the RNA the gene therapy are really the only 2 therapies that are available. I think and everybody's on therapy, so that number is probably about the total. Somewhere probably around 10 total.
About Spinraza, I know it has been used for a long time, and
yes, but I'm talking about diagnosed by newborn screening.
Okay, thank you so much.
Thank you, Professor Vockley. Is there any question? Because he's kindly with us for any Q&A right now, not to wait till the end of the session. I wanted to thank you, and I want to tell a question. Actually, for the whole genome sequencing, as you said, it makes more relief from the diagnostic odyssey of most of the genetic disorders. But what about breaking the bad news when you did the whole genome sequencing for patients during a newborn screening?
Well, we haven't done newborn screening yet, to be clear. We've been doing NICU testing, and in the setting of a seriously ill child, talking to the parents about a result is really no different than any other test. They're not. They're happy to have an answer, even if they're not happy about what that answer is. Newborn screening is really going to be very different, and that's why having a limited number of diseases that are covered in the early going, limited to those that are only those that have some therapy available is really going to be necessary. You're not going to want to talk to families about diseases that are going to show up in 5 or 10 or 50 years. That is not really a good way to handle it. So that's why I talk about the screening for life paradigm, where at age appropriate times you unmask additional data that then allows you to see what risks that individual has in the coming years across their lifespan, rather than trying to just do everything as a newborn screen.
And actually, as you said before, for the fetal demise, which proves to be highly beneficial when you do whole genome sequencing for identifying couples, even with those children. I did actually in King Faisal Specialist Hospital and Research Center a great study on such cases, and it proves to be highly beneficial, even to reach the diagnosis and help those miserable couples to have a good quality of life and to know the diagnosis of their children. Thank you very much.
You're welcome. And I guess I have another question and answer session later. Is that this one? Should I stay on, or should I come back at the next time?
Thank you very much.
All righty. Bye bye.
I couldn't hear well.
Oh, yeah, I was asking.
I don't think currently. I think all the audience, no one have any questions. So thank you very much for your great time, and kindly will join us for the next session. Thank you.
Very good. I'll be back. Thank you.
Thank you. Sorry for the interruption. Again, I'll start by la homocystinuria definition, hyperhomocystinemia definition. Homocystinuria comprises a number of disorders of homocysteine metabolism united by the common biochemical findings of high plasma and urine homocysteine concentration. Hyperhomocystinemia is implicated in the prosombotic tendency and the neurological features associated with all of these conditions. Therefore, lowering total homocysteine is a major goal of treatment, which in turn necessitates an understanding of the range of differential diagnosis of homocystinemia to ensure correct treatment is initiated. Just here, I wanted to focus on homocysteine metabolism. This figure actually, it will give us the clue for the coming slides. I can use the mouse. Okay, as we can see here, as we can see from the start, methionine is essential amino acid which cannot be synthesized in our body. It has to be taken from the diet, and the main source is dietary protein. And methionine is converted by S-adenosyl methionine and S-adenosyl homocysteine. It is converted to homocysteine, and then homocysteine is converted to methionine. This is a remethylation pathway, which can use a methyl donor, which can be either from 5-methyl tetrahydrofolate, which requires methionine synthase with methylcobalamin as a cofactor, or betaine homocysteine methyltransferase also as a methyl donor. As we can see here, homocysteine is converted to cystathionine by CBS enzyme, which requires B6 as a cofactor, and then finally into cysteine and cysteine. And this is called the transsulfuration pathway, and here this is called the remethylation pathway. Elevated homocysteine can be attributed to a variety of conditions. For example, as we can see, plasma total homocysteine, usually a normal range is 10 to 15 micromole per liter. And I want to say that when we suspect hyperhomocystinemia, we have to do sampling for an expert lab with unique results, because there is great importance for sampling for the result. The others, for such example, genetic factors, vitamin deficiencies, folate, B6, B12, chronic kidney disease, drugs such as metformin, methotrexate, nicotinic acid, and smoking can be attributed to increased homocysteine. What about the genetic causes? The most important of the genetic causes is the classical homocystinuria, which I'll focus today, caused by cystathionine beta synthase deficiency, and it is the most common genetic forms. There is other genetic forms such as remethylation defects, which are beyond the scope of our session today. For classical homocystinuria, again, I want to say here, if we can see, if there is a deficiency of cystathionine beta synthase, so there is elevated homocysteine together with increased methionine and decreased cystathionine, and this is a biochemical hallmarks for patients with classical homocystinuria. And the elevation of methionine is very important to differentiate between the disorder due to remethylation or classical homocystinuria. There is a wide range of spectrum of severity from individuals who are currently asymptomatic to those with severe multi-system disease with a wide age of presentation. Some patients have a severe adulthood multi-system disease, while others are asymptomatic into adulthood, and this is attributed to the to the degree of enzyme deficiency. The phenotype broadly relates to pyridoxine responsive, where we do have pyridoxine responsive versus non-responsive, and the incidence is greater in the Qatari population, most commonly inherited metabolic disease there, with 1 at 1/400. Untreated patient with CBS deficiency, plasma total homocysteine concentration usually above 100 micromole per liter. And again, as Professor Vockley had mentioned, thanks for newborn screening, which identified and patients who treated early and have good quality of life. The clinical presentation for organs or for systems are involved ectopia lungs or severe myopia, which we saw common for those untreated patients, for patients who are pyridoxine non-responsive. And excessive height and length, this is called Marfanoid habitus, osteoporosis and bone deformities. There is intellectual disability, seizure, psychiatric problem, and the thromboembolic manifestations such as morbidity and mortality, which is the most common symptoms for adult presentation. And here, I want to say for the classical homocystinuria, current treatment relies on diet, betaine, B6, folate, and B12, and the diet has to be given for all patients, whether pyridoxine responsive or non-responsive, who didn't attain a recommended total homocysteine level, which is below 50 micromole per liter for those responsive patients, and below 100 micromole per liter for those unresponsive. So most pyridoxine unresponsive patients require diet that is low in natural protein with supplement of methionine-free amino acid mixture that to attain normal growth for those patients. In a children, betaine 100 to 200 milligram per kg per day, divided into twice daily. In adult 3 gram twice daily. B6 100 to 500 milligram per day. Whether folate 5 milligram daily, and B12 1 milligram. But the most important things for the treatment of patients with homocystinuria is the poor compliance is a major issue. For this reason, there is unmet or utmost need for the presence of novel therapies to help to improve the quality of life of those patients. Novel therapies, we can see here, there is novel therapies which will act on methionine to help to decrease methionine. For example, there is gamma lyase and the probiotic, and there is metabolite modulator, and also for homocysteine, there is enzyme replacement therapy, and the chaperone therapy, as well as gene therapy. Here I want to say that Traverse Therapeutics has sponsored just an enzyme abigailed modified version of human cystocyanine beta synthase, and now they started investigate the efficacy and safety of pictavadinase compared with placebo in patients more than 12 years to less than 65. And actually, it proves its effectiveness in decreased both total homocysteine as well as decreased methionine in the initial phase 1 and phase 2 clinical trial. And now they opened the 3 multi-center, multinational randomized blind placebo-controlled study, and it is estimated completion in January 26. And it will be potentially for pictavadinase to come the first disease-modifying treatment for classical homocystinuria. And I wanted to say again that this global study proves its effectiveness, and now it opens to be multinational. Again, by this figure, I wanted to show here the current approaches for development of a novel therapies, or still in the clinical trial, but hopefully it will become soon for the novel treatment of those patients. Here, as I've said, development of probiotic therapy and an oral enzyme therapy. also in the bloodstream, and here current approach and the novel therapies for the homocysteine, such as the enzyme therapy. In conclusion, I want to say that current treatment options for classical homocystinuria are very limited and often inefficient, particularly due to low patient compliance with very strict dietary regimen, especially in children. Patient progresses in research and the development of a new therapies for homocystinuria. It will give hope for immediate and long-term health benefits and the better quality of health for those patients. And it is anticipated that the increased availability of a new therapies will stimulate research toward improving diagnosis of homocystinuria early in life and increased awareness about the disease among healthcare professionals and policy markers. And those are my reference, and I'd like to thank you very much.
Thank you, Dr. Ola, for very nice presentation. First of all, I want to thank the team of genetics department, Ain Shams University, for their kind invitation. Dr. Sawi, Dr. Aizza, Dr. Suleb, Dr. Ola, Dr. Shaima, and all of you. It's a great pleasure to be with you all today. It's a great pleasure to me to present my dear sister, حبيبتي زي ما بيقولوا بالعربي, Professor Dr. Huda Yahya Tamoom, the head of Pediatric Neurology Department Ain Shams University and the founders of the Electro-EEG unit, Children's Hospital Ain Shams University. She's a member of the ECNA and the British Pediatric Neurology Society and the International Child Neurology Society and the American Academy of Pediatrics, and she was awarded several times in her life. She will talk about adolescents and adult onset inherited neurometabolic disorders, a great challenge.
Thank you for the genetic team for inviting me. We have always been collaborating together. اوكي احنا نص حالاتنا جيناتيك ونص حالاتنا اوتو اميون، فثانك يو جيناتيك تيم فور اولويز collaborating with us، واحنا لازم نشتغل دايما سوا لان ده الواقع يعني. اوكي I will present one of the cases which present later on in life. It was a great challenge because you do not really expect a neurometabolic disease so late in life. Okay, this is A. He's a 12-year-old male boy of cousin parents. He was completely normal till the age of 10.5 years. ابتدى يجي لنا ب unsteady gait, frequent falls، بس الفانكشنز بتاعت الهاند والسكول were normal. هو لسه لحد دلوقتي ما جالناش. ال MRI brain and spinal cord were done. ميرسي يا حبيبي. ال MRI brain زي ما حضراتكم شايفين في هنا كده ليجن في لا مش مشكله. السباينال كورد زي ما حضراتكم شايفين في حته كده وايتش كده ماتر، وايتش سيجنال في السباينال كورد، فدي كانت واخده السيرفايكال انتراميدالري ليجن، والفيجوال ايفوك كانت ديلاي، فالعيان ده كان البوسيبيليتي اتعمل له، اتفكر طبعا ان ذيس از ديمالنيتنج ديزيز، فاتعمل له الورك اب بتاع الديمالنيتنج ديزيز انكلودنج الاشهر انتي بودي بنعمله لما نفكر في نيورومايلايتس اوبتيكا اللي هي الاكوابورين، طلع نيجاتيف، بس ستيل في حاجه اسمها اكوابورين نيجاتيف نيورومايلايتس اوبتيكا، يعني افكتد ديمالنيتنج في السباينال كورد، خلاص دي نيورومايلايتس اوبتيكا. He was diagnosed وخد IVIG وميثايل بريدنيزولون، no improvement. ووصل بيه الحال انه he used to walk with a walker، مش قادر يمشي independent. وبالفولو اب كان الام ار اي سباين الديمالنيتنج ليجن فيها ابتدت تبقى فيد وابتدت تبقى اكرونيك ديزيز. القصه ما خلصتش كده، حاجه غريبه جدا، نيرلي في نفس الوقت اخته ظهرت. اخته دي وقتها كان عندها 10 سنين ونص. She was completely normal لحد the age of 9 years. nearly at the same time، مش عارفه ليه ابتدت هي كمان to present with diminution of vision. هنا بقى الفيجن هي كان mainly vision، هو كان mainly motor، هي كانت vision أكتر، وابتدت تبقى unsteady gait و easily falling. still her hand function, her speech, her school were normal. ال MRI spine brain، أنا آسفة brain was normal. السباين ابتدى برضو يبان في مش عارفة شايفينها ولا لا، الابنورمال signal intensity دي في السباينال كورد، وكانت long segment again ماشية مع neuromyelitis optica visual evoked delay. واحنا كده كأن برضو another case of neuromyelitis optica. نفس الكلام، نفس الانفستيجيشن، aquaporin negative، فيتامين دي قليل شوية وخلاص. with time الجيرل ابتدت تبقى incontinent، وابتدى الفيجن يورسن، وابتدى السكول بيرفورمانس يقل. هي مش شايفة، مش عارفة تقرا ولا تكتب. again methylprednisolone no effect. so هنا هي جات لنا بعد سنة ونص من بداية المرض. الاكزامينيشن مور اور ليس ذا سيم، نفس الفكره. هما الاثنين عندهم generalized weakness في رجليهم، وابتدى حتى يدخلوا، الولد حتى ابتدى يدخل في deformity في الهامسترينجز وهايبر ريفلكس. اوكي، والبنت مور اور ليس ذا سيم، بس هي الفيجن بتاعها كان اسوء. طيب فهنا السؤال، ايه البوسيبيليتي ان هما الاثنين يبقوا نيورومايلايتس اوبتيكا؟ طبعا احنا كلنا عارفين ان ديمالنيتنج او الاوتو اميون ديزيز كلهم لهم جيناتيك باك جراوند، لكن مش للدرجات دي يعني، مش للدرجات دي يعني. فابتدينا نقول لو مش نيورومايلايتس اوبتيكا هيكونوا ايه؟ فاحنا عندنا ا بيج ديفرنشال دايجنوزز للنيورومايلايتس اوبتيكا. في ديزيز اوتو اميون كتير كان بريزنت زي النيورومايلايتس اوبتيكا، بس ستيل احنا عايزين نطلع بره الاوتو اميون. احنا بنفكر دول كازن بيرنتس ايه اللي ممكن بريزنت. البيبر دي was looking for spinal cord involvement in adult onset metabolic disease. هم حطوا لنا جروب اوف ديزيزز كتيره، ليوكوديستروفيز، ديزيز ريتد للفيتامينز، جيناتيك. فاحنا as usual احنا كانت الامكانيات يعني ضعيفه، فقلنا look for treatable conditions. فبعدنا على الليوكوديستروفيز لان كلهم ما فيهمش تريتمنت. بعدت على الاكوايرد لان مش معقول اثنين اخوات يبقوا عندهم اكوايرد ديفيشنسي، مش منطقي. فلتس لوك فور تريتابل كونديشنز ان سيبز يعني. فقلنا اوكي هندور على يعني فوليت وهايبر هوموسيستينوريا، بايتونيديز اقرب حاجات. فابتدينا بالبايتونيديز. profound deficiency. اوكي، وبعدين ريتروجريد بقى. احنا عارفين كلنا ان ساعات بيبقى معاهم ميتابوليك اسيدوزس وساعات بيبقى معاهم تشينجز في الميتابوليك سكرين. لقينا في هيدروكسي ايزوفالاير كارنيتين عالي في الاثنين. بقت الحاجات كلها نورمال. I mean الحاجات الميتابوليك يعني. None of them had the characteristic skin manifestation you would expect. البنت كان عندها شوية hair falling but not to raise attention. شوية شعر بيقع، مش حاجة فظيعة. طيب عشان ما ضيعش وقت رهيب قوي يعني، هو البيوتين احنا بيجي لنا من سكتين، من الاكل ومن البيوتينيديز. بياخد البيوتين هيجي لنا من فوق هنا من سكتين، من الاكل ومن البيوتينيديز. البيوتين ريسايكل من البيوتينيديز بيمسك في حاجه اسمها ابوكاربوكسيليز باي هولوكاربوكسيليز سينتيز، يطلع لنا الهولوكاربوكسيليزز. بعد كده يطلع في الاخر بالبيوتينيديز، يرجع البول تاني عشان يدخل يلف اللف. السبب ان البيوتينيديز له يعني wide variance of manifestation ان هولوكاربوكسيليز دول are involved in pyruvate carboxylase. فالديفيشنسي بيعمل هايبوجلايسيميا ولاكتيك اسيدوزس. في الاستايل كو اي كاربوكسيليز الديفيشنسي ياثر على الفاتي اسيد. البروبيونايل الديفيشنسي يعمل بروبيونيك اسيديمز ويقلل الاكتيفيتي بتاع السيتريك اسيد سايكل ويعمل لك ديفلوبمنتال ديلاي. في الميثايل كاروتينايل والديفيشنسي يعمل لو كارنيتين وانكتيفيتي. فده السبب في الكلينيكال بيكتشر دي. رغم ان احنا كلنا عارفين ان البيوتينيديز بريزنت ان ايرلي انفانسي بهايبوتونيا وسيجرز واتاكسيا وسكين راش والوبيشيا وهيرنج لوس واوبتيك اتروفي. Still, in older children, it presents with spinal cord and optic nerve involvement. بطيء ليه؟ دول البيبرز اللي لقيناهم بقى، قعدنا ندور لقينا عندنا البيبر الاولانيه اتكلمت على 4 children presenting in childhood or adolescence with profound delay biotinidase deficiency. profound لكن غريب you present with this age زي عينتنا بالظبط. spinal cord هنا في 3 Chinese 7 and 1 year of age. تحتدوني وقت عشان البتاع البطيء ده. البروفاوند بايتونيديز في 3 سنين وهنا واحد تاني في 7 سنين، والغريب ان هم كلهم بروفاوند. اوكي، ودول بايتونيديز presenting like a multiple sclerosis، ودي بايتونيديز presenting like a neuromyelitis optica زي our patients، وanother one like a neuromyelitis optica. البيبر دي شافت الحالات اللي presenting biotinidase later on in life، لقوا ان الايج اوف onset of reported cases كانت 5 و3 و7 سنين و5 سنين وسنه وادولescence وسنتين. معظمهم معاهم visual impairment بس مش كلهم، حبه منهم معاهم hearing impairment مش كلهم، حبه معاهم alopecia او skin rash مش كلهم، حبه معاهم optic nerve مش كلهم، بس اشهر حاجه كانت ان spinal cord affected في السيرفايكال والثوراسيك. For the sake of time I will leave this. قعدنا كده لمده كذا سنه نفكر، طب احنا اللي عرفنا ان العيانه دي بايتونيديز ان هم كانوا اخوات. How many cases are we missing؟ مش اخوات. فقعدنا جبنا بقى رساله وعملنا رساله على كل الحالات الديمايلينيتنج اللي ندور فيها في البايتونيديز، وقعدنا كذا سنه ما نلاقيش ولا حاله، لحد ما الواحد بعد شويه ابتدى الموضوع يطلع من دماغه. جات لنا many years later جات لنا البنوته دي 10 سنين non-consanguineous parents non-consanguineous totally normal. Her complaint was abnormal gait progressed slowly over 2 months with no sensory affection أو urinary incontinence. بعدها بشهرين ابتدت تسوق جدا bilateral severe upper limb weakness وابتدى visual affection، ودخلت عندنا لقينا ان عندها hypothesia في رجليها، مفيش movement خالص في ايديها في رجليها، وايديها كانت يا دوبك 3 proximal وديستال 2، مفيش reflexes incontinent. الام ار اي فايندنج كانت حاجه بسيطه جدا بتلف حوالين البيري اكويدكت، وده المكان اللي بتحبه نيورومايلايتس اوبتيكا. فاجين احنا قلنا دي نيورومايلايتس اوبتيكا، خصوصا اللونج سيجمنت اللي في سباينال كورد. والفيجوال ايفوكت ماشي. اكوابورين نيجاتيف مش مشكله، عندنا حالات كتير نيجاتيف، وفي حاجه اسمها نيورومايلايتس اوبتيكا نيجاتيف، فيعني مش هي دي اللي ضد يعني. فالبنت اديناها ستيرويد بلازما فريسيس ما استجابتش. 3 sessions of plasma pheresis البنت deteriorated ودخلت الاي سي يو. حضرتك فاكره يا دكتوره امنيه لما دخلناها الاي سي يو؟ وبعدين خدت IVIG مفيش تحسن، قلت خلاص دي بقى ندخل على ريتوكسيماب. بس قبل ما ندخل على ريتوكسيماب كان برضو بقى لنا كام حاله كده بنشوفها CNS HLH، فقلنا لحسن دي مش بنت مش تيبيكال ات اول، دي عماله بتسوق ودايما الديمايلينيتنج انسلت ات بروجريسز رابيدلي وبعدين بلاتو. دي بنت قعدت تسوق شهرين، فقلنا دي شكلها احسن تكون HLH قبل ما ندخل بريتوكسيماب. الاب يعني كتر خير وافق وعمل لنا الايه الهول اكزو. الصفحه اللي وراها بايتونيديز ديفيشنسي، هو ما حطهاش في الوش، حطها في البوتنشالي ريليفنت. وعلى فكره انا خاطبتهم وقلت لهم I just want to tell you that this patient can fit biotinidase. قالوا لي we cannot depend على ال just incident report. فبرضه دي نقطه مهمه ان الواحد لازم يقلب الصفحات. فالبنت دي في الاخر طلعت biotinidase confirmed. دي الاخت الاولانيه انا ما وريتش حضراتكم، ما عنديش لها فيديو اب. دي فيديو بعد 10 مللي جرام بايوتين. في اليوم. احيتك الدوزز المكتوبه 10 ل 20 وفي ناس مزودين ل 40. احنا ما شاء الله عندنا لازم نزود ل 40. دي بعد 30. البنت دي لو حضرتك تفتكروا دي كان الفيجن عندها very bad. دي الفيجن خلاص she does not need any visual aids, she is cool performing very well وبتنط واخر اجرام. اخوها حضرتك تفتكروا اخوها ده، حضرتك فاكرين الفيديو الاولاني ده اخوها بعد بايوتين 40 مللي جرام وكم عمليه في رجليه عشان كان وصل الى كونتراكتشر. فيعني الامبروفمنت مش زي اخته رغم ان هم نيرلي ذا سيم تايم، بس هي كان ووك الون. حضرتك فاكرين منظره قبل كده. للاسف البنت الثالثه للاسف الامبروفمنت بتاعتها، معلش ممكن نشغل الفيديو؟ معرفش هو وقف ليه. الامبروفمنت بتاعتها ما كانتش as marvelous as الفاميلي الاولانيه. هي دلوقتي ايديها رجعت، still she is still incontinent و she is still يا دوبك feels below الامبلايكس. وده يوضح ان يعني رغم حضرتك تفتكروا ان الولد والبنت الاولين قلنا بعد سنه ونص، بس الامبروفمنت بتاعهم بالذات البنت كان مارفلس، الولد كان معقول. البنت دي للاسف الامبروفمنت بتاعها is so slow على الرغم ان patients they are doing their best في الريهاب يعني. طيب طبعا العينين دول they need follow up بالاكستندد ميتابوليك سكرين عشان لو اي يعني ديفيشن من نورمال، وبالاي بي ار وبالفيجوال ايفوكت وكده. طيب اخر حاجه البيبر دي بيبر I think at 2019. هي بتقول هي في فرنسا وانجلترا البايوتين دايز is not as a newborn screen يعني is not in the newborn screen. ف they were discussing if they are missing cases of biotinidase because it is not in the neonatal screening in UK ولا في فرنسا ولا في عدة بلاد تانية زي إنديا وإيران وألجيريا ولا إحنا طبعا. فهم they were stressing that it should be put in mind especially in cases with demyelinating insult لأن هي it can be missed as an autoimmune disease. Thank you. أعتقد إن أنا in time. Thank you.
شكرا جزيلا دكتورة هدى. فعلا البيوتين يعني بصي احنا عندنا حاجه كده في وحده الاعصاب عندنا لما بنشوف حاجات بنعمل لها ريز اويرنس. ففعلا لو دورنا على الحالات دي هنلاقيها. فبقول لها لسه بهدى انا في عيان انا شكيت ان هو بايوتيدينيز، شكيت جايني بكونفالجنز وسبيرس هير كده وفاتح. وبصت على البنت الثانيه لقيتها عندها الوبيشيا وهيرنج لوس بس نورمال انتليجنس وعندهاش ابليبسي. فانا قمت بقى ايه وانا هستنى، قمت ضاربه بايوتين على 40 مللي جرام. العيان اكتسب كل النيور ديفلوبمنت، اتحسن. ولسه الاهل معهمش فلوس يعملوا هول اكزوم، ولازم كنت ماشي في ترتيبهم فهنعمل بايوتيدينيز بس. فهي increase the awareness. الواحد لو minded بالحاجة هيلاقيها. فالتريتابل بالذات ربنا يسهل يعني تبقى في مخنا جميعا. شكرا.
Thank you, Professor Dr. Huda, for this valuable and informative presentation. And it's my pleasure to introduce the last speaker for this session.
هو السكريننج فور بايوتينيديز موجود تبع المبادره، فاي حاله سسبكتوا فيها بالنسبه للحالات النيورو ممكن جدا نستفيد بالقصه ونعمل لها التحليل، مش محتاجه هول اكسو. بنعمل بايوتينيديز انزيم وبنعيده، ولو طلع قليل قوي زي كده نبتدي بعد كده بقى بندي الثيرابيوتيك دوز ونشوف الدنيا. احنا كنا بنسميها دايجنوستيك دوز على فكره. المبادره الرئاسيه المبادره للنيكيوز سيلكتيف سكريننج اوف 19 جينيتال ديس اوردر ان نيكيوز. لو حالة زي دي يعني حضراتكم كلموني ونحاول نضمها للمبادرة as exception مش saving lives احنا معاكم. انزيم assay وطبعا بتطلع ريزلت ما بتتأخرش يعني. اي حاجة لكن مش احسن من الهول اكزوم الهول. دكتورة أمنية كانت بتقول بنعمل بايوتينيديز. بيتعمل فين؟ في فارماجي ولا فين يا دكتورة؟ في المعامل المركزية؟ لا ما بتتعملش. في المركز قومي البحوث بس تبع التأمين يعني. طب خلاص خليها نعملها عندنا ونسيف اللايفز مع بعض ان شاء الله. انا بعتذر.
First of all, we have to thank Dr. Yasmin Gamal for sharing with us her valuable time, because we all know how precious her time is because of the endless responsibilities. Dr. Yasmin is an associate professor of pediatrics and clinical nutrition in Ain Shams University. Currently, she is the director of the Children's Hospital Ain Shams University, and we have to mention that she has 16 years experience in pediatric clinical nutrition. Now she will share with us a very nice presentation about the ketogenic diet in inborn errors of metabolism, epilepsy, and beyond. Dr. Yasmin, the floor is yours.
Thank you, Dr. Shaimaa, for the nice presentation. It's always a pleasure to be amongst my professor and colleagues. I thank Dr. Ola, Dr. Sulef, and the whole medical genetic department for the kind invitation. والحقيقة I'm always proud. يعني أنا لما بحضر حاجات MDTs كلها في عين شمس العيان بيتشاف من all the specialties. We are teams, the best results الحقيقة. It makes me يعني always proud. وطبعا collaborations مع وزارة الصحة من الحاجات اللي بتتيك us forward في ال diagnosis of our patients. أنا هحاول أكون سريعة جدا. أنا عارفة it was a long day وأنا اتكلمت بعد أساتذة كبار وقامات يعني. ودكتورة هدى دايما بتأميزس بالحالات اللي بتطلع غريبة. بس أنا طبعا يا دكتورة هدى بركز في IVIG وفي تمام. في الفلوس اللي اتصرفت. بس it's worth saving lives. هو ده هدفنا في الآخر وتقديم the best quality that there is for our patients. This is all our goals. This is what keeps us as teams. طيب ده بيهنج بغض النظر عن الأجندة. keto diet من الحاجات الترندي that we are facing nowadays, a lot of research and a lot of search. لأن هو بيستخدم in a lot of array of disorders. لو احنا بنتكلم على metabolic disorders أو بنتكلم على epilepsy. Apart from this السيرش العالي قوي لأن هو it is used in metabolic derangement من أول الأوبيزيتي للهايبركوليستروليميا. a lot of الحقيقة indications. والرحلة بتاعت الكيتو دايت is amazing. It is a dietary intervention that دلوقتي is searched more than scientific papers. طبعا it is really popular. وعلشان نبقى عارفين هو what is a keto diet. A keto diet is a high fat diet. And I'm mimicking the body. I'm using another substrate. احنا we know that glucose is the favorite substrate of the body. What I aim for is ان انا ادخل البودي in a state like starvation with high fat diet and decreasing the carbohydrates. ف it is a high fat low carbohydrate diet. هدفه ان انا استخدم الكيتون as a substrate for the metabolic disease rather او for the epilepsy rather than using the glucose as a substrate. So ketosis, this is what we aim for, and amazingly ketosis الحقيقة one of the main beneficiaries of the ketones in the body is the brain. And the brain cell with enhanced neuroplastic plasticity, network plasticity, brain functions are improved, neurogenesis improved, mitochondrial functions are improved. Apart من known effects of ketosis on the insulin, increasing insulin sensitivity and lipolysis and improving the diabetes in some patients. So what is really evidence-based to use a ketogenic diet for? Epilepsy, cardiovascular disorder, obesity, of course, weight reduction, and diabetes. What are the emerging evidence to use in some
of neurological disease, and it's really the era of using now the keto diet for memory disorders, Alzheimer's disease, because increasing the brain function, polycystic ovary syndrome, and sometimes with some types of cancer like the gliomas. And we did study the ketogenic diet in some other disease like the autism, where we published a paper which proved to be beneficial regarding the cognition, but it was really equivalent in the control of a casein-free and gluten-free diet. How does the keto diet work in managing epilepsy or in bypassing some pathways in metabolic disorders? A lot of suggested pathways and suggested functions are introduced. Rather, nobody knows how exactly does it work, whether it's increasing the GABAergic activity or mitochondrial biogenesis or decreasing glycolysis and stabilizing the blood sugar. A lot of suggested mechanisms of action. Nobody can put the hand on the exact mechanism of action. In epilepsy, it's like magic. It is one of the lines of therapy. Seizure control, more than 50% reduction in frequency, more than 90% reduction in frequency, around 30% of the patient, and 65% of the patients were more than 50% reduction. Freedom, seizure-free patients, 10 to 15%. Okay, now this is an important photo الحقيقة. We started the keto clinic in our university in 2012 with the combination of the neurology unit and the clinical nutrition unit, and we were pioneers in Egypt and in the Middle East in having a multidisciplinary team, a combined team, the keto clinic, and we were serving more than 300 patients so far along the 12 years of giving the service to the patient. So patient selection depends on the neurologist. It starts with the neurologist actually, or the metabolic expert or geneticist. He is the one who refers to us, and the indications are clear. Drug refractory epilepsy, failure of adequate trials of 2 or more drugs, appropriately chosen and taken by appropriate dose, whether as monotherapy or combination, and metabolic condition as highlighted is the glucose transporter deficiency and the pyruvate dehydrogenase deficiency. It's effective, of course, in a variety of epilepsy syndromes, and we have a good experience in implementing the keto diet in a lot of syndromes like the Dravet, the TS, the infantile spasm, the super-refractory status epilepticus. We have tried the parenteral keto diet, so we have good experience in implementing the keto diet in a variety of epilepsy syndrome. We have also some metabolic disorders that we have tried the keto diet in, and this is a very nice review about ketogenic diet interventions in inborn errors of metabolism done in Turkey 2024. So I've been telling you that the keto diet is on the rise, and they are trying it in a lot more inherited metabolic disorders nowadays with good success and good, they are pilots, of course, very few number of patients, but very promising results. The most frequently inborn error of metabolism is the glucose transporter defect, and I believe 12 years ago, we were rarely diagnosing glucose transporter defect. Nowadays, we are diagnosing glucose transporter a lot, and this patient has no other way rather than a ketogenic diet. So the glucose is not transported to the brain, so the CSF glucose will be decreased. The patient would come with refractory epilepsy, not responding to anything. Everything is normal, and more we are diagnosing these patients, and their only way is to find another substrate, and another substrate is the ketone body. So they are using ketone body as a fuel for the patient with glucose transporter defect, and this is a treatment or a nutrition intervention for life. So the patient with glucose transporter will be on ketogenic diet, different types of ketogenic diet for life. Another inherited metabolic disorder, and these are papers starting from 2010, implementing the keto diet in glucose transporter defect, even implementing other modalities of keto diet like the MAD in glucose transporter defect. Another inherited metabolic disorder is the pyruvate dehydrogenase, where there's a defect in the pyruvate dehydrogenase, not using the pyruvate in the Krebs cycle. So the glycogenolysis is disrupted from the Krebs cycle, so the patient will have lactic acidosis and no energy whatsoever, no ATPs. So I need to find another substrate for energy for this patient. And another substrate is the ketone body through the ketogenic diet. So high fat, low carb diet, ketogenic diet is the only solution for pyruvate dehydrogenase deficiency patient. Glycogen storage type 3, it's the main idea. A lot of papers and publications and controlled series of patients on ketogenic diet in glycogen storage disease type 3, where there's deficiency of a debranching enzymes and glycogenolysis is limited. So we need to find another substrate, bypass this pathway, and keto diet has eucaloric keto diet improves energy balance in these patients, and modified Atkins diet was reported to lower the CK, the creatine kinase, and improve cyclic AMP in 8 pediatric patients with glycogen storage disease type 3. Type 5 is limited and restricted mainly to exercise, right, Dr. Muhammad? So they were giving trials of sucrose before the exercise, or giving other substrates other than glucose for patients with glycogen storage disease type 5. Keto diet has been proven in an array of 20 patients of improving the hypoglycemia and the muscle weakness that happens with these patients. Okay. Another rare inherited disorder, I don't know وقف اساسا خالص, is the NKH. أبص لدي؟ Okay. The NKH is a severe form of refractory epilepsy. I know the neurologists, they hate it, and when they refer it to us, and the geneticists, they hate it, and we hate it as well, because really difficult patient to handle, difficult intervention. Even if it's a nutrition intervention, it's not that easy. It results from mutation of the enzyme that reduces the activity of glycine cleavage enzyme complex, and we need to decrease the glycine pool of the body. So we need to use the glycine gluconeogenesis, and ketogenic diet is a way to decrease this glycine pool and decrease the needs of sodium benzoate in this study. And there was a very nice study in 2022 about the combination of low dose sodium benzoate with the ketogenic diet 3-to-1, improving the seizure frequency in NKH patient. Complex 1 mitochondrial disease. These are the papers I highlighted, 2020 and 2022, around 22 patients and 14 patients, whether they are with multiple complex mitochondrial disorders, and 7 patients out of the 14 patients were seizure-free. And this is amazing to my, practice. If I'm having 14 patients with mitochondrial disorders and 7 are seizure-free, this is a life-saving diet. Reduction of seizure greater than 90% in 1 patient, and reduction of seizures between 50 to 90% in 2 patients. Another good series of patients were the MELAS patients, and there were around 22 patients, and they all reported reduction in seizures. So it works in mitochondrial disorders, whether it's complex 1 or 4, but there are more research needed in this area. Is my patient fit for ketogenic diet? So if I diagnosed a patient with glucose transporter defect or pyruvate dehydrogenase or refractory epilepsy patient, are all patients fit to have or to start the ketogenic diet? We have to rule out contraindication, and extended metabolic screen is mandate for this to exclude fatty acid oxidation disorders, carnitine metabolism, porphyrias, and some mitochondrial disorders. Pre-diet workup includes basic lab, CBC, kidney, renal functions, extended metabolic screen, urinary organic acid, lactate, ammonia, and of course the MRI and the CT and the CSF would be done before referral to the keto clinic. Nutrition assessment, because if the patient is severely malnourished, it would be really difficult to start a diet, a highly restricted diet. So we have to do good anthropometric measurements, diet history, know the food preferences, allergies, aversions, and intolerance, and put a good nutritional plan. Pre-diet counseling is really important. So this is a patient with an inherited metabolic disorder or a patient with refractory epilepsy. So counseling is the core of ensuring compliance of this ketogenic diet. So we have to start counseling. بنقعد مع العيان 2 or 3 sessions, ساعة ونص أو ساعتين كل واحد, describing what is the keto diet. احنا الحقيقة I was lucky working with دكتورة أمنية, هي بتعمل تقريبا نص الشغل بتاع النيوتريشن, وبيجي لي العيان already counseled and he knows what is keto diet. He just wants to know the steps to follow to implement this diet. We shift the medications. So we have شوية tips and tricks in the keto diet. منها the patient has to be on tablet form, and all the oral forms are syrup. عندي شوية drug nutrient interaction like the steroids. They negate the ketosis اللي بيطلع. Topiramate side effects combined, لأن keto diet بيعمل لي a kind of dehydration و increase gravels مع topiramate برضو عنده has a side effect. valproic acid already to metabolize the fat I need carnitine. فالvalproic acid أو dipakine consume this carnitine. فif he is deficient he will not metabolize the fat, he will not enter in ketosis. Few tips and tricks by experience and putting the patient on systematic steps الحقيقة they will not be missed. Supplementation is really important. It's a high fat, low carb diet. So there are no fruits and vegetables. Most of the fruits and vegetables are out of the diet. Most of the legumes and the high fiber diet are not there. These patients need multivitamin preparation, additional the calcium, vitamin D, polycitra to alkalinize the urine because we are hot countries. Selenium and vitamin B were added in our keto clinic because we did research that proved that our patients are defective in selenium and antioxidant vitamins. So no fruits, no fruit juices, no breads, cereals, pastry, no vegetables, no milk. We can only give the keto milk or the keto that we have in our clinic. Snack foods are contraindicated, and we give them a nutrition regimen according to the type of diet that we choose to the patient. We have different types of diets, starting from the classic ketogenic diet, 80% fat, 20% proteins and carbs, up to lesser degrees of keto diet in control, but more malleability, like the modified Atkins diet, 60% fat, or even the low glycemic index diet, 50 to 60% fat. Which diet is best according to the patient? Which age? Classic ketogenic diet in our center is implemented in infants. Less than 2 years, it's really easy to implement for them. Above 2 years of age, we have to give a lot of preferences. بنرفع لهم البروتينز والcarbohydrates a little bit so that compliance would be better. So we combine the modified Atkins according to the child oral feeding skills. If he is on gastrostomy tube or feeding tube, classic ketogenic diet would be optimum for him. So the choice of diet is according to the child, the condition, and what are we expecting. طبعا عندنا ranges من 2 to 1 to 4 to 1. وعندنا basic steps of calculating the keto diet. عندنا calculators. We have specific kitchen. We implement in our center the modified Atkins diets. And the modified Atkins is easier. So I don't count except the carbohydrates. I give them ample proteins, ample fats. Every meal has 50% to be fat from the sources of fat. And we give them only, we count only the carbohydrates. So this is an overview of the keto diet and the patient journey. And I would like to thank all the teams involved because keto diet is not one specialty implementation. It's not nutrition only. It's nutrition and neurology and genetics and the social worker and the nurse and the metabolic kitchen we have in our university metabolic kitchen for the keto products. And I would like to thank them all and thank you.
Thank you, Dr. Yasmin, for this informative talk. I have one question for you. Do you recommend that we should start by ketogenic diet for patients with NKH? Should we start with the ketogenic diet before we start sodium benzoate and other medication? Will this result in better? لا NKH النون-كيتوتيك هايبرجلايسيميا. لأن كل الأدوية يعني احنا كلنا اهو بنشتغل NKH. احنا انا مش شايفه الأدوية انها بتعمل حاجة. يعني مهما بتقلل من بتقلل من السيرم جلايسين او البلازما جلايسين، بس ما بتقللش من CNS جلايسين. الحاجة الوحيدة اللي هتقلل الكيتوجينيك دايت. ليه ما نعملهاش حتى study؟ تمام، يعني why not حتى تعملوها يعني.
I have only one child with non-ketotic hyperglycemia. Her ammonia was not increased except in infections only. No need to sodium benzoate. L-glycine inside the brain. EMS بتاعها كان نورمال. البنت دي عشان كده بقول لك EMS were normal. I diagnosed her with whole exome and she improved a lot on keto diet and now she stopped her keto. I don't have a patient with high glycine with non-ketotic hyperglycemia. ممكن ناخدهم ونحاول بقى نظبط سوا.
I wanted to add something what I know for our according what is written for literature for NKH patients. Just we do have the severe neonatal form. Severe neonatal form already which presented early already had bad prognosis. Despite even fatal with CNS abnormalities, even if you started to have even ketogenic diet has been written or in what we had been written for literature about a patient with NKH has been used only for refractory epilepsy. Just try like the goal of ketogenic diet for such patients, but only even more patients came to us asking, do we start the ketogenic diet from day one when we diagnosed our patient? Even for the recent update, what is written for the NKH patients, just to follow according to presentation. If early neonatal, it is severe prognosis, whatever you start, and then if you had even milder form, you start to escalate to sodium benzoate just to decrease glycine, and then. But the role, what will be the role for ketogenic diet per se? The role for controlling the epilepsy, it is not for control. For controlling the epilepsy, but you do have patient. You have patient. I'm not debating about you don't know, but I'm saying that about in the goal of the ketogenic diet, a role for epilepsy, not for that. Actually, في patient NKH وفي group without seizure. وفي group without seizure, وفي group. I have a lot of patients even if they didn't start ketogenic. And my opinion or what has been written, if they do have seizure, we can start to see the effect of ketogenic diet on those patients.
سؤال دكتورة هدى، ميرسي جدا طبعا على الحالة الرائعة دي. كنت عايزة أسأل، لما قلتي إن في الثيرابي في البيشنت التاني كانت استجابته أقل من الأولاني، احتمال جدا يكون التايب اوف ميوتيشن، يعني لو تايب ميوتيشن نون سنسيف واحد، النون سنسيف تبقى مور سيفير، الميس سنسيف تبقى أقل، أو يكون الميوتيشن بتاعت واحد كانت في مكان غير الميوتيشن بتاع التاني بيأفكت الدومين بتاع البروتين اللي بيشتغل. في حاجات بتبقى كريتيكال وفي حاجات مش كريتيكال، او الريسبتورز. ما هو بالظبط، ما انا بقول يعني ان اكسكلود ان في حاجه از موليكولار ليفل هي اللي مأثره على الريسبونس بتاع العيان. في انتر لا في انترا فاميليا فاريابيليتي عشان الموديفاير جين تبقى فيها. لا، ما هو انا قصدي ده علشان احنا برضو بدينا نلاقي دلوقتي يعني عيان كان اميون ديفيشنسي، ودكتوره هاله في الفيزيوثيرابي لقت سودو هايبرتروفي وما كانش اكسبليند خالص لحد ما لقينا في الانسيدنتال فايندنج في مايو ادينايت او حاجه كده ديفيشنسي بيعمل سودو هايبرتروفي في الجسم. فانا بس بقول على دي للريسبونس. شكرا.
Actually, today, right now, we are going to the end of our second session. And it would be grateful for all our speakers who spoke about interesting talks, but actually because of the time is 15 minutes, a second time it will be more.